And here we come to our last panel for this evening. And here comes the poll. Can we have the results, please? No, yeah. 50% of them feel that we don't have a perfect healthcare ecosystem. Fourth and last topic for this evening. How can a perfect healthcare oncology ecosystem be created? As a moderator for this session, we have Dr. Nicole, Senior Director, Colleague Wellness, Pfizer Inc. USA. And our panelists are Dr. Arnie Purushottam, Director, King's Health Partner, Comprehensive Cancer Center, London, and Consultant Surgeon. Mr. Prabhat Sinha, Head Communications, Patient Advocacy and Policy, Novartis Oncology, Novartis India Private Limited. Mr. V. Kumar, Emerging Markets, Oncology Team Lead, Implementation and Alliances at Pfizer Inc. USA. And Mr. Girish Nair, Founder of Access Life Assistance Foundation.
Good afternoon, good day, and good evening to all of you. We are happy to be here today to discuss how can a perfect healthcare ecosystem be created for oncology. We have many great panelists with us today. I am Dr. Nicole Shaffer, and I am from Pfizer, and also have supported VCare organization for a while in some other working that I have been doing. And it is a great passion of mine to be able to work with VCare, and I'm honored to be able to be here with this great panel. So we have panelists from many backgrounds today, and so I'm going to let them go around and introduce themselves quickly, and then we'll jump right into the questions. Dr. Kumar, do you want to go first?
Hi. Hello, everyone. My name is Kumar, and I would like to first and foremost thank Vandana Gupta for having me in this panel today. And we have been associated and working with Ms. Vandana Gupta for more than a decade now in various projects. I lead the oncology marketing for emerging markets in Pfizer. I'm based out of the New York headquarters, and happy to be a part of the panel today, looking for solutions, how we can together improve the outcomes for patients.
Thank you. Next.
Great. My name is Prabhat, and I'm based out of Bombay. I head patient advocacy, policy, and communications for Novartis Oncology. A subject which I was not aware maybe 6 years back, patient advocacy. And I have worked almost half of my life working with nonprofit, working on advocacy for blindness, for disabilities. And first time somebody told me patient advocacy in a pharmaceutical industry, I was astonished. I didn't know how it is going to happen. But believe me, after 6-7 years of working in India and seeing the potential of partnership venues that exist to work together for making therapies accessible, making care accessible, making better screening program accessible, it's a new world. Country like India, we are still on a journey which we have started with partners like VCare. A lot more to be done. But I'm very, very pleased to be with each one of you on this forum. And thanks to Vandana ji for inviting me here, and also Dr. Nicole for having me here on this panel. Thanks.
Thank you. Next.
Thank you, Vandana and VCare, for your kind invitation to be part of this panel. I'm Arnie Purushottam. I'm a breast cancer surgeon and academic based in London at King's College London and Guy's and St. Thomas's Hospitals. And I'm the director of King's Health Partners Comprehensive Cancer Center. I've had the pleasure of working with my Indian colleagues for many years, especially for the last 3 years until December 2019, working with the Tata Trust as the medical director for their cancer care program. Thank you again.
Thank you. Girish?
Good evening, everyone. First of all, I'm sorry. I try to make it on time. I'm still driving, so you can probably hear a lot of background and see a lot of background happening behind me. Thank you for having me, Vandana ji. I am the founder and chairman for Access Life. We are a non-profit which deals with pediatric cancer. What we do is we provide shelter for children who are undergoing the treatment of cancer. We started in 2014 with our first center.
So thank you again. As you can tell, we have a very diverse background in our panel, so we will jump right in with these questions. So we've prepared a few questions to talk about the overall thoughts around the oncology healthcare ecosystem, and especially now as we've undergone the pandemic. We know there have been a lot of restrictions on the frequencies of in-person visits. Even in Mumbai, the changes in how cancer treatments have been normally administered. When I was there in 2019, remember how many people were coming from so many other parts of the country and coming to the cancer center in Mumbai to be able to get their treatments. And we know that has not happened since, that there have been so many restrictions on that. So, again, thinking of how that affects cancer care and the thoughts of how this may change the future of what cancer care looks like. So the first question I would ask to the panel is, since the pandemic, a lot of healthcare work has changed with the frequency of visits to where treatments and appointments are performed. So how do you see this affecting or altering the way oncology care will be performed and managed in the future? So any of you can feel free to just respond.
Okay, let me take a first shot at this question. Yeah, no doubt we are facing an unprecedented times with the pandemic devastating healthcare systems around the world. No one imagined last year at this point of time we will be in this situation. We have now reported more than 98 million cases around the world and more than 2 million deaths. So one thing which came out of this pandemic was that how our healthcare systems, we had inadequacies, and it got more exposed and exacerbated during this pandemic time. One of our biggest challenges definitely in cancer care has been an impact on decline in screening. And this will have a long-term impact, leading into a late diagnosis, and maybe potentially it also will have on the treatment outcomes and more deaths happening on this one. This is one of the first and foremost thing which comes to my mind because of the pandemic, the issues which has been there. The other aspect is that one is a disproportionately high impact we see on older people, lower income communities, rural communities, and that communities which always had issues with holistic or healthcare disparities which was being there. And that communities are impacted far more because of this pandemic coming in. I think this pandemic has been a deadly one. We all know that one. It's never been in the past. In the recent past, we have seen this one. But what is important is that one is we need to get collectively our message out that cancer cannot be quarantined. Okay, so the patients and the people need to step out, whether it's for regular screening work or following up their treatment schedules, which are being there. They should not miss it out on that. Once the disease progresses, there is no looking back on that one. I think it's collectively as an industry, from our partners and other stakeholders who have been in the cancer care, should come up and educate the public that don't wait. Yes, we need to take precautions when we go out, but just don't keep delaying on that. We started on multiple such kind of campaigns in Brazil and the United States and other parts of the world. I think it's something which we need to do far more for people to step out and don't wait, get the treatments being taken on that. So that's what I'll put it across. I'll chime in once the other panelist gets a chance to continue on this question.
Thank you. Dr. Arnie, I saw that you were ready to comment as well.
No, thank you for that. So I think what this pandemic has brought to my cancer institution and many others around the world is some very good things, and we've noticed some not so good things. And I'm going to touch on the positive things. We've started thinking completely outside the box in terms of what we do for patients. So the idea here was not to get the patients to come to hospital if they didn't need to come to the hospital. So most 75% of our consultations switched overnight to telephone consultations or video consultations. Patients got more control over when they could reach us, so they had more access to us, but it was virtual access. If we needed to see a patient, we would phone the patient and encourage them to come. Patients were scared to come to the hospital because the government messaging was very strong, which was stay at home. So we had to overcome that by actually proactively talking to patients and telling them that the NHS was a safe place to come, and we were taking the necessary precautions. We implemented some new things that we hadn't done before. We worked in collaboration with St. John's Ambulance to go to the patient's homes and take their blood samples for their routine investigations when they were on treatment for cancer. So these patients didn't need to come to hospital for their routine blood tests or blood tests before they get their chemotherapy. We worked with the community pharmacies so patients could pick up their drugs that they needed from the pharmacy rather than come to the hospital or go to the GP. And finally, we accelerated the adoption of de-escalating treatments, which were proven in trials, but we were yet to adopt them. So fewer fractions of radiotherapy for certain types of treatment, like breast cancer. The downside is what we've just heard articulated so well, which is our patients were frightened. They were not going to their GP. They were not coming to the hospital. And we now have very good evidence, which we've just had accepted for publication, that our patients are going to be presenting with later stage disease, a switch from stage 1 and 2 to stage 3 and 4. And that is going to inevitably going to impact on their treatments and their overall survival. Thank you.
Thanks. Prabhat, what are you hearing or what are you seeing in the pharmaceutical space? So, Mr. Kumar talked about some of the educational pieces around screening. What are you seeing in the Novartis space around this, or other topics for the healthcare ecosystem?
So, I think the first thing is what Mr. Kumar told, that cancer cannot be quarantined. I think it's a very powerful statement, because what we have seen in last few months, that and especially country like India, where cancer care is so centralized, so smaller cities, they were all time dependent to come to major metros, be it Chennai, be it Hyderabad, be it Bombay. Once this lockdown happened, the whole confusion was there. And this confusion, whether it's selling drugs to newer patients or replenishing the stocks or getting access to care, follow-up, these were questions nobody was prepared, because we have been discussing about decentralizing cancer care, but the need to decentralize cancer care was, something that everybody started talking. And as Mr. Purushottam talked, I think from this pandemic, whenever a pandemic like this happens, definitely in that particular year, people who are victim, but I think the future generation will benefit out of it. Few things that is going to happen. If you see the decentralizing cancer care, now everybody acknowledges. Even when we talk about our PMJY, the National Health Authority, the biggest so-called PMJY scheme, the way while the OPDs at tertiary centers have gone down, the OPDs in tier 2, tier 3 cities have gone up. Government has started publicizing in newspaper on the district cancer care centers or chemotherapy centers which they have started, saying that you don't wait. If you have an issue, go to the district hospital. But our district hospitals were not prepared to provide a quality treatment. But at least whatever was there, they started imparting that. Targeted therapies. It has been years while the cancer care, the way cancer is being managed, it has been changing. But country like India, we are still over dependent maybe on chemotherapy, whereas targeted therapies give more freedom. It reduces out of pocket expense. When there is an oral tablet can cure or can potentially extend life, give a quality of life. Why I need to travel 1,000 kilometers just for chemotherapy? My own cousin, I know he stays in a place which is almost 1,500 kilometers from Bombay, where I am. I could not convince him to continue his chemotherapy in a city called Ranchi, where he belongs to. He preferred to come 15 times to a city like Bombay. The amount what he invested for drug was negligible, but the amount what he invested for airfare for him, for his wife, the amount of time, loss of job, staying outside, these are all out of pocket expense. This is going to be changing, and there is a strong move what I see. Second is the need for telemedicine. See, this particular act was there lying for years. Suddenly, in the month of March onwards, government made teleconsultation in India legalized. Now, and it is not a teleconsultation like I take at my home, booking an appointment to Apollo Hospital. It could be in India a model, it is an assisted telemedicine, where at a PHC or at a district hospital, a primary care physician is there. And then with the assistance of that primary care physician, that patient can be seen from a tertiary care center like Tata Hospital. Now those models have been started. I sitting in Bombay, I consult my doctor in Bangalore because I used to stay in Bangalore for long, and I still have a confidence, and I just choose my doctor in Bangalore. That freedom I got. But for me, the luxury is that I still have a doctor in Bombay. But believe me, in a smaller city, even getting an access to a doctor in Chennai or Bombay is a luxury. Now, this is something which is a byproduct of this whole COVID era. The third very important thing is the overall awareness generation on innovation on clinical trial. And thanks to COVID vaccines, at every household, people are becoming experts, which is not good. But they have started talking about phase 3. They have started talking about phase 4. They have started talking about innovation, research. And I think the resistance that people get on clinical trials and all, at least there is a overall general positive mindset that will emerge. So I take a lot of positives. Another thing I wanted to highlight is the connect between patients, where I have been very watching the space that during pandemic, patient support groups in India has got platform like Zoom. It existed before, but we never used it. We never used Microsoft Team apart from our own business discussion within organizations. I had never used Microsoft Team or Zoom as a platform to connect Vandana ji, for example. Leave it organizations who are across the country. Immediately after March, we started connecting on virtual platform. And now a hospital like Tata Hospital, lung cancer patients, they started connecting virtually, not in 10, 50s, hundreds of patients every Friday. Now, these are the positive things I feel that, and then many, many things. This belief, this trust, this confidence is going to give a long way in Indian healthcare system.
Thank you. Girish, I know you're still driving, but I would love to hear your perspective on how the pandemic and the healthcare situations with children, because again, you're thinking of a family system at that point too. Children aren't coming by themselves, and how that sort of changes and impacts. So what are you seeing from the point of view of cancer care in children and their families, and how that structure may have changed, or what it looks like going forward?
Well, it definitely was a lot of change, especially for a non-profit like us who runs a shelter. What we do is we run a shelter for families who are coming from far off places in India to hospitals like Tata. Now, pandemic sort of made it very difficult. Even before the pandemic, it is very difficult for a non-profit like us to actually get a space where we can accommodate these families. Generally, there is within the housing societies, there is a resistance to sort of accommodate the families who are undergoing treatment of cancer. Now, what happened with the whole pandemic was the children, as you know, Mr. Kumar rightly said, cancer cannot be quarantined, and the children had to sort of go to the hospital. So the residents were not really very happy, because when we rent a place, it's in a residential area and there are other residents staying there. So they were not really very happy and very comfortable with the fact that these children were still going to the hospital and coming back, because the moment they step out of their homes and come back, they sort of become a potential carrier of COVID. So it has in fact made it very difficult for us to find accommodation, to an extent that one of our center, which accommodated 12 families, we had to shut that center because there was heavy resistance from the housing society, and we had to close that center down in Thane. And fortunately, we were able to sort of build a new center, but that again took us about 4 months. So uh, accommodation is one aspect. Transportation was another aspect, because we used to provide transportation to the families to go to the hospital and come back. And during the late hours, if they were late, they used to use the public transport. Now, without any public transport, we had to engage a nighttime driver for any emergencies. So, a lot of things have changed for these families. Uh, and we had cases where when the child used to go to the hospital and one of the child did turn COVID positive. So, the whole isolation, having to put the family in quarantine, working with the hospital, and then to manage the entire neighbors, when you're staying in a residential complex. So all those things became really difficult. And we had so many children who had to sort of, come for their follow-up treatment at the hospital, and they couldn't because there was no transport. And families who completed their treatment, they couldn't go back to their hometowns again because there was no transport available. So getting an accommodation, especially after the COVID, from a point of view of providing shelter, has really become difficult for us. In fact, the very reason that I'm in a vehicle right now is because we were trying to open a center in Pune, and we have seen so many places. People are ready to give their places for rent, but they don't want to give it for children or anybody who is undergoing treatment of cancer.
Okay, thank you very much. So our second question really comes to a lot of what we've already talked about. So I think let's highlight some additional pieces. And while we all know that the pandemic has been very devastating in many aspects, I think even in your answers to that first question, we can see some of the opportunities that have also arisen from the pandemic, things that we wouldn't have thought about, or things that would have delayed and taken us many years to think through. How would it work? How wouldn't it? What should we do? What shouldn't we do? We didn't have time for that. We had to really make decisions in real time, and if it didn't work, we had to change course a little bit and try to keep going. And so my second question to all of you really goes to, what do you think the perfect oncology ecosystem should look like in the future, and what services or specialties should we include to best meet those patient needs? And I'll just give a couple that you've already suggested. Telemedicine, the abilities to be able to communicate with your patients, and the infrastructure, video or by phone. And also some of those remote opportunities to have their treatments. So as you talked about in the UK, having their bloods drawn at home versus them having to go someplace else. So we talked about in India, more targeted therapies where it wasn't strictly full chemotherapy regimens in a hospital. And even from the screening side, I think we're going to find we need to be a little more creative in how we can get people back into the system for screenings. And then from the transportation and even accommodation standpoint, we know is so important in India and many other countries as well. But I think, again, it's we really saw the disparities in healthcare amongst different populations and different groups, and how do we work to really make that ecosystem still meet the needs of patients and their families, but also look at what we've learned from the pandemic going forward. So thoughts?
Shall I start?
Absolutely.
So So I think, I mean, the lessons I learned when I was working in India for 3 years with the Tata Trust was, and we used Assam as our state, our model state, was that the key things here were awareness, access, and affordability. So the model that we developed in Assam, which is being developed in other states in India now, is a hub and spoke model. So you have a few major centers, and then you have step-down centers. And this is about infrastructure and care. So level 1, level 2, level 3, and level 4. You have public health wrapped around it. So both prevention and early diagnosis. And in early diagnosis, I embed the screening program in that. And within this, the access to palliative care, because many patients present late in India, and psychological services, I think, should start from the very beginning when you're looking at an ecosystem in cancer care. And each of these, I think, need to be addressed individually. So you've got the awareness not just of the public in terms of red flag symptoms, awareness of where the screening centers are so they can gain access to screening and understand why they're being screened, and then what happens after that, because many patients fall through the system. Even if they're diagnosed with cancer, a number of them don't actually reach care. The second is awareness in the healthcare and the community healthcare workers, the ASHAs, the ANMs, the GPs, the primary care practitioners, as well as dentists. Patient navigators to allow patients to reach the healthcare facility, and ideally locally. And Prabhat has indicated very clearly the issue of traveling 1,500 kilometers to the Tata Memorial, that needs to change. The Tata Memorial can't handle all these patients in the first place. So I think a distributed care model, care closer to home. Prabhat mentioned telemedicine. I'd add teleradiology and telepathology into that as well. And the key thing about affordability, which colleagues, all of you on this call are fully aware, that's got much better in India with the Ayushman Bharat scheme, as well as the local state schemes. But getting patients to understand how to access these insurance schemes, I think is still a challenge. So I think wrapping around all of this, I would put education across all the people that I've mentioned to ensure that you create an ecosystem that's distributed, that's affordable, and that's accessible for the patient and their families.
Great, thank you very much. Mr. Kumar?
Yeah, just have to add on a couple of things. From the Pfizer point of view, we are committed to supporting the advancement of cancer care around the world, and also partnering with the organizations who can meet or address this cancer burden of cancer care around the world. One such example I want to give is the City Cancer Challenge. This was a part of the UICC earlier, and now it's been a standalone organization. What they highlight the work which is being done is that a couple of things which I want to bring it across over here is unlocking the power of collaboration. The issue at hand is enormous. Okay, and no single institution or an organization can solve this one. How can we bring in all the partners together to work, and then and also see that one is to make sure, like Dr. Purushottam mentioned on that one, is that for me is biggest thing is the local expertise and knowledge. Whenever such kind of a programs have been there, involving the local experts is very, very critical in getting these programs and up and running. The other one is on engaging the relevant stakeholders. When I do tell about the stakeholders, a little broader context over here. The local, national governments, that's very critical on that one. Hospitals, academia, patients, patient groups is very critical when we look at the entire treatment journey for cancer patients over there. When we look at even the specialties, it should include all of them: pathologists, nuclear medicine, cancer surgeons, medical oncologists, palliative care. And I just want to emphasize on palliative care. This is most often missed out specialty when we speak about the relevant stakeholders and working across on it. Get this one and build a minimum standards for cancer care in the country. Okay. And once again, I just don't want it to be adapted at global or international guidelines. We need to look at it based on the resource available, what best we can do for each of the countries over here, and then putting these stakeholders together, coming across on that one. I want to highlight in India one positive development which is coming with National Cancer Grid. By and large driven by Tata Memorial Hospitals, is connecting the hospitals across the country, both in the public and the private sector. And not just connecting on that one, they are also laying down the guidelines which needs to be followed up. More focused from an Indian context of what the delivery has been there. I want to see this more adoption happening across. It's a journey. I'm not telling that one is we can get the results in tomorrow, but I'm sure that one is in coming years, we can see that the quality of the care coming across by engaging on that one. And that was my last point in terms of forging the connection between the public and private. The experts might lie in either side of the aisle. So I want to make sure that one is the communication happens well. Sharing of the knowledge, it's very critical in how they treat the patients over there. And essentially for me is contributing to standardization of the care in India. We see that one is like Prabhat mentioned earlier, Dr. Purushottam mentioned on that one. We have an islands of excellence in India, right? And that's predominantly in the metro cities over there. And that's where the public confidence and trust is that one is anything to do with cancer, I need to travel. I need to go to Tata Memorial Hospital, even if the appointment is 2 months, 3 months down the line, but I want to get an advice from them. Now, I'm so glad that Tata Memorial Hospital has put in this second opinion concept, a project Navya they are working on, where anywhere in the country, patients can send across the details of the test reports and what the initial diagnosis has been there, and they get an advice which is what they would have got treated in Tata Memorial Hospital with a multidisciplinary approach and advice being given. I want to really see the scaling up of such kind of initiatives which is there. By and large, then they get a comfort that if I had gone to TMH in Mumbai, what I would have got treated, I'm getting the same kind of a treatment in a nearby center, right? And that's something which I want to see more happening across on that one. Finally, my point is that when any of these plans in a perfect ecosystem to work on, we need local ownership. I emphasize on this one is we have many projects, many plans on that one. The execution has to come from the local ownership coming in on that one, because it's very much varied in a big country like India, in terms of the resource availability, quality of care which has been there. So it's kind of you have to customize the programs for the local need, and then the local, the ownership needs to be there, and also working with, so that we can have a sustainable treatment over a period of time. So that's what my final message would be on that.
Thank you. Girish, do you have a thought on what the future needs to look like in your space? You know, we've talked about the accommodations and the transportation and the challenges that the pandemic has brought in several of those areas, but what are your thoughts for the future? What do you see needing to happen or continue or stop happening?
I totally agree with Mr. Purushottam. What he said was, we need to have more, treatment centers across the nation, because right now there is too much of load on hospitals like Tata Memorial, which is based in Mumbai, and a lot of patients coming specifically to, certain hospitals. If we had more hospitals throughout the nation, like how the Tata is going along with the National Cancer Grid, and if there are more local support happening at those areas, the concentration of patients to one particular city or state would be much lesser, and the treatment that can be provided can be, much better in terms of that.
Thank you. Prabhat, any other things that you would think?
So I think in addition to what Mr. Kumar and Dr. Purushottam has said, in India, we need, I was writing and I said, we need another VAT, VAT. And this VAT is, the first VAT is the voice of patients. In our healthcare system, what we are lacking is the voice of patients. They don't get a seat on the when, for example, National Health Authority makes a plan. Do right patient voice, and I want to re-emphasize right patient voice. Get a seat on that table who are aware about what is happening in the oncology ecosystem in that space, so that people, and I have seen in my personal interaction with NHA authorities, they are very open. But most likely when they meet with the people, they don't meet with the right people. And if they meet with the right people, they are very, very open to change. Why, after 2 years in India, the daycare facility for chemotherapy is not part of the package? Drugs are there, but you need to be hospitalized to get benefit of a drug which is mentioned in cancer care. For imatinib, do a patient need to be hospitalized? This is there in the package for last 2 years. Now hospitals are getting patients hospitalized, giving 15 days of imatinib, and then releasing that. It's not a win-win situation for anyone. It just needs somebody to raise voice and say that this is not right. Make an exception for cancer care. 80% of the things can be given, let's say, in a daycare basis. You don't need to hospitalize the patient. That's why I say that voice, the voice is needed. The second is we also need to amplify that voice. The voice exists. As I said, I never knew there are so many patient advocates. Not only in Bombay, even smaller cities have very, very solid patient voice. But we have not heard them. We have not listened to them. Now, this voice needs an amplification. As Mr. Kumar said, these voice needs to come together. That collaboration is going to transform. And the third is the transformation. The role that many times the non-profit patient groups have taken, that needs to transform with time. For example, if there is a big program like NHA, now people should start seeing that how do we make this NHA run on ground, because it's a 500,000 Indian rupee being reimbursed, and push this 5 lakh rupees maybe a little bit higher, or to make certain amendment in that, but not start duplicating what NHA is doing. Still, we are duplicating in many parts, right? And this will allow system to sleep. They will go in deep sleep in some parts. And that is where we need to impose this VAT, this time from the other side on government. Voice, amplify, and transform. This is very, very important. And the second is, we have to move away from pocket of excellence. We take pride of what we do in a small pocket. This is not going to change the system. We need a truly healthcare system approach. And what Dr. Purushottam has shared, we need more hub and spoke model like what is in Northeast. When Tata Hospitals open a new center in Varanasi, see the OPD load. Thousands and thousands of patients do not have to come from eastern part of the country to Mumbai. We need this hub and spoke kind of model. We don't have to only emphasize on service delivery. The healthcare system has other building blocks also. Do we talk about MIS? Do we talk about human resource? Now, post-COVID, the another important thing is the standardization of training and standardization of curriculum for not only for doctors, but also for paramedics and also for frontline workers. That is where the screening and the early detection and the follow-up is going to transform. So these are the two major buckets that I wanted to share. Thank you.
Thank you. So we are coming down to our final minutes of this fantastic discussion. And I think that we've actually talked about some of those challenges moving forward. We've talked about opportunities. And I would just say, let's close with each one of you telling us what you think is the one area that we can start really focusing on to improve that overall ecosystem. And everyone's touched on many, and they've touched on things that have gone well, but we know we can't turn a switch and tomorrow everything looks completely different. So what is the one thing that you think we should be focusing on in that ecosystem that will have the biggest effect right now, where we can really start impacting that? And I would also add, how can VCare also be able to support those changes? We know that Vandana is extremely active in the patient advocate space, as well as the whole leadership team and organization. But again, from that nonprofit standpoint, How do we move that forward? What's that additional voice look like? What do some of these other things? So what is that one area that we can start right now to focus to make the greatest change going forward?
So Nicole, I'll look at it from a strategic point of view based on the experience I had in India. The one thing we realized very early on was that, we being the Tata Trust, that if we wanted to do something meaningful at scale, and here we're talking about scale for a 35 million population in Assam, is we had to get the government of Assam to sign up to this and to buy into this vision. And so the funding came from both the Tata Trust and the government of Assam. So you had a partnership here with the state government and with the Tata Trust, which is a foundation, and together they own the project. And I think that is what has made this project is making this project a success, to do this across the entire state for the entire population. And I think strategically, I'm now helping colleagues in Kerala, and we're doing exactly the same thing. Getting the Kerala government to own what we're trying to do, and there it's a private partnership with the state government of Kerala. So I think there are many models here, and one needs to look at the whole ecosystem in health that India has, right from NGO, private, and state and central government.
Thank you. Who wants to go next? Share their thoughts.
So, one thing which is going to bring a lasting change is the trust. So Mr. Purushottam talked about Tata Trust, but I think the trust is what each one of can put in the system. And if you see the trust between government and the non-profit, the trust between patient groups and healthcare, not only pharma, but also with diagnostic and many other players. I think what we need is the trust. Currently, the way in last 1 year or maybe 2 years, the whole ecosystem is changing. There is a revolution happening, whether it is National Digital Health Mission, whether it is Ayushman Bharat, the new Medical Council Act. There has been enormous changes. Now, these changes are not going to sustain if this trust and partnership is not there. And then we will start complaining that nothing works in our country. Things will work when we extend our support, not to duplicate things, but to offer that little support to that. The way National Digital Health Mission is coming, the way 40% of our population is now covered under National Health Authority, our PMJY program. Now, and that is going to also cover the missing middle class now, what I heard. So that means instead of devising another program, everybody should develop that trust and try to see that how on ground the execution, which is the bigger piece in our country, it's not the money is not the issue. The issue is all about execution. And this execution will come only and only we will have trust and not complaining on systems, just partnering and taking things ahead.
Thank you. Mr. Kumar.
Okay. One thing for me, which comes in a perfect ecosystem where in the country like India, we need to focus foremost would be on capacity and capability of cancer care. There is a huge gap here, and I think is all stakeholders have to work in increasing the capacity. I see over the years, there has been an improvement in the private sector, in particular in cancer care. New chains of hospitals coming in, going beyond metro cities to tier 1 and tier 2 cities. But still, there's a lot more need to be done from a public sector's point of view is concerned. We have regional cancer centers, but the quality of the care and the infrastructure has to be upgraded. Government has made its intentions of enhancing the care at the regional cancer centers, building new cancer centers, as well as key government medical colleges. They want to have the dedicated cancer care centers. I want to see this one not just mere an intent statement to actual reality in a time-bound fashion. I want to emphasize once again what Prabhat mentioned is on execution. We have a plan, but it's make sure that it's been executed on a time-bound fashion on that one. Once there is a capacity has been built up, okay, a physical infrastructure over there, it's the human capital which needs to be also the capabilities needs to be built up. Entire in this value chain on that one. It's from the paramedical staff, oncology nurses, to radiologists, pathologists, and even the cancer specialists. Today we have so less number of medical oncologists to treat the cancer burden in the country. They are overwhelmed. You can't expect a medical oncologist to provide that quality time with every patient where the patient loads are very high. So what I wanted to really look at it is how can we reimagine the things and set out priorities on what can we do in a short term, a medium term, and long term. All problems cannot be solved in one go, but can we have a path forward and stick together? And this is where emphasize, as I brought in earlier, engagement with a broader stakeholder is essential to the sustainability of the program. If that's not been done, that frequent changes in the plan, we don't see that one as the execution and a necessary outcome coming out on that one. So key for me is capacity building, capability building in India to, if you look from a good or a perfect cancer ecosystem to be there.
Thank you. Girish, last thoughts?
So the reason why non-profits like us exist is because the reason why we are into providing shelter, nutrition, transportation is because there is a lot of emphasis on improving the treatment and opening more cancer centers, but it is equally that much important to sort of provide this non-medical care. What we have noticed from our experience is that when families come here for the treatment, and when they do not have a proper accommodation, counseling, transportation, and all those services, it leads to abandonment of treatment in a lot of cases. So as much as importance is given towards the care and opening many cancer centers, the need to provide secondary non-medical related care is also equally important, and that's something which the government also should consider when they are opening different centers across the country.
Thank you. And I just want to take the time to thank all of you. These have been great discussions, such different points of view, yet we all come back to the same areas of focus. And it really all does revolve around the patient, as it should, and how we need to look forward into these new times. But I think there are great opportunities to be able to make our healthcare access, the affordability, the overall treatment plans, and consistency across the board, across the country. So again, thank you to the entire team of panelists. And of course, thank you to our wonderful sponsors and leaders from VCare for having us today to be able to have these discussions. So again, thank you all for participating, and we look forward to speaking with you again soon.
Thank you very much.
Thank you very much. Thank you.
It was a varied conversation coming from different spectrum of patient advocacy. Thank you all. So here goes our last poll question for the fourth panel. Results, please. Cool. Get it first. Right. I now welcome Ms. Jogita Jagwani, a patient advocate, fundraising and events coordinator at VCare. Jogita, all yours.
We don't want to take any questions, Jyoti.
Yeah, I have a few questions which I will take, and I'll ask our panelists.
Dr. Arnie is also here, right? So
Yeah.
if you have any.
Yeah, so
Good evening.
First of all, I must thank each one of you because Mr. Kumar is in New Jersey, Mr. Purushottam is in London, and Mr. Prabhat is at the airport, and all of them have joined in, which is fantastic. And I'm really, really very grateful to each one of you. So before Mr. Prabhat goes into his flight, let me ask him one question. And that is that, you are saying that you would be able to support any voice, which is a right voice and all that for the patients. So one is how would you be able to guide us on that? Secondly is how did you manage the couriers, etc. during COVID time? And also, do you have any new access programs for the patients? So Mr. Prabhat, can you hear me? Can you answer the question?
Yes. Am I audible?
Yeah, you are. Maybe you might have to switch off your video for better quality of sound. Anyway, Mr. Prabhat, I'm presuming that you are saying that you are going to help us all, that you are going to start new programs because there's a lot of noise in your bus, and I would like to believe that that is what you are saying, right? So thank you. Thank you for doing that. Mr. Purushottam, I want to thank you for changing your appointments and being with us. So I know the conditions in UK are now getting worse or probably getting better because the last couple of days was really bad. And you think if a situation like that existed in Mumbai, because you've been working here, you've been to the various starter centers and all that, do you think it could have been handled as effectively as it is being in UK, or you think we are handling our situation in a better way as of now?
It's a really interesting question because I think we have been looking at India very closely and seeing what has happened during the COVID pandemic crisis. And obviously I'm very close to the Tata Memorial Hospital, and I have regular conversations with Dr. Pramesh and his team. We draw comparisons between how we've looked after cancer patients in the UK during the COVID-19 pandemic and how the Tata Memorial and other sister hospitals have managed. And I think one of the mistakes we have made in the UK is the messaging was very strong to stay at home. And what we are seeing is the consequence of that in our cancer patients. So we saw a precipitous drop in the number of new cancer patients attending for care. So they had symptoms, they had signs, but they did not present to their primary care practitioner. And so we didn't see them. And it started in end of March, April, when the first lockdown happened. We still haven't recovered from that. We have now also seen initial data suggesting that patients are presenting with late stage disease as a result of neglecting their presentation. And that for us is something that we're really concerned about, and we're going to see that over the next year. In terms of COVID per se, India seems to be doing pretty well and has not suffered the same second wave of the pandemic that we have seen here in the UK. We're just about beginning to recover, Vandana, and hopefully with the rollout of the vaccination program, which is going extremely well, 14 million people have been vaccinated, at least the first dose in the UK, there is a light at the end of the tunnel. But the messaging now to our cancer patients and to the public is if you have any symptoms, please seek medical care and don't wait to be seen. And the screening programs have also opened up again. So we've started screening breast and colorectal and cervical cancer patients again, the public again.
Thank you. There's a thing going on in India that you need to take only one vaccine as of now, one dose of the vaccine, and that is fine. But in UK, I know people have taken their second dose. Most of them have taken their second dose. So is there a difference is it because of the difference in the medicine, or is it because that's the right thing to do, or is it because of the huge numbers that we have here?
So the majority of the people who've had their vaccine in the UK have only had one dose, but the second dose will happen very soon. There is all the data suggests that you need 2 doses to get maximum protection. And I think if you only give the population one dose of the vaccine, you will underprotect the population in terms of the immunity that you have in the community. So definitely 2 doses for both vaccines. And what you currently have in India is 2 vaccines that have been licensed. And both vaccines, the trials suggest that you need 2 doses.
Okay, so while we are talking about the vaccines, and first of all, congratulations, Mr. Kumar, for the wonderful Covishield for your vaccine, which was the first to come in from Pfizer. I don't know, I'm sure you are extremely proud, but I'm even prouder because of my association with Pfizer. And so I feel as if, I've made that vaccine. So it's that much of a pride in the whole thing. So what I wanted to know, very often we get these questions from the patients saying that, is it safe for them as a cancer patient to take the vaccine? So would you have something to tell us about it?
Maybe Dr. Purushottam will be more qualified than me to answer that question with regard to the particular setting of patients getting across on that one. Purushottam, would you mind answering that one? Then I'll come back to the general thing on vaccination. Yeah.
I'd be happy to tell you what we are doing in my hospital. Once we started rolling out the vaccine amongst the healthcare workers and the elderly population, starting with the age range of 80 and above, and then dropping to 75 to 80, we started vaccinating our cancer patients. So patients who were either inpatients in the hospital or who were attending as outpatients were given the option of having their first dose of vaccine. I don't know the exact percentage who've accepted it, but the overwhelming majority of patients have accepted their first dose. So we are rolling out the vaccine to our cancer patients because we think it's really important that they are protected. Obviously, there will be individual patient circumstances where the oncologist would prefer us to defer when they're immunologically suppressed because of their treatment, then we would wait till their immunity gets a bit better before we vaccinate them. But the general rule is vaccinate as many cancer patients as you can who are prepared to be vaccinated.
Whether it is solid tumors or whether it is blood cancers or those having BMT, anything at all.
So that's where the advice from the oncologist and the hematologist would be really important. So clearly with hematological cancers, it's different from solid cancers, and it's also what type of treatment they are on and what their immunosuppression is. And all of these we take into context with the individual clinician. And if they say it's fine for the patient to get vaccinated and the patient is agreeable, then we go ahead and give them the vaccine.
Okay, thank you. Mr. Kumar, I'll come to the vaccine part for you. And I also want to say that you said that you will, for the UIC slogan, you had said that you will work for equitable cancer care, which means a lot. So tell us about that and also the vaccine part.
Okay, a couple of things on this. When I meant that I commit for equitable care, it's been something which has been a journey for the last 15 years, which has been there. When I look at access for cancer or innovative medications in overall, which is there is very loose definition has been looked across when there is an interplay between access and affordability. Access is much more larger stuff, which is there right from the awareness, diagnosis, treatment, and post the treatment when the care which is need to be provided for the patients on that one. So I think we need to work across the spectrum or the patient journey on that one. So that's one part I want to bring in. Affordability is an issue. I'm not telling that one, but it's not the only issue. There is far more things to be looked across. That's number one. Number two is that one is when I tell the equitable care is it starts from Pfizer is publicly committed that one is right starting from the clinical trial stage. There were not a representation of certain communities in the clinical trials which was done in the past on that one. So we are making sure that one is in future that there is straight from the drug development process that there is a representation of all or a broader community in terms of making sure that the clinical trials are being done. That's one part from the drug development process which is there. And we did that one even in the COVID vaccine stuff. If you see that one is, it's in the trial, which was very clearly that one is, there was a large percentage of white population, but Hispanics and the Black communities were also represented and other countries which has been there. And it was by design it was done. That's the difference which has been there earlier. And there are certain communities like they are not more willing to participate in clinical trials, maybe from like historical reasons which is there, but how do we educate them and get them to be part of the clinical trial process? That's one thing which is there. Second is that one is, how do we make sure that one is the diagnosis happens much more better in certain communities or rural communities where it's not been so much which is there. Here is where we need to think about reimagining the way we are looking on diagnosis part. One of the examples is one we are working with a couple of startups in India is on the breast cancer. One of the areas we were conventionally doing this mammograms. We took some of the buses fitted with mammograms going to the rural communities, but still the scale it cannot happen, right? It's a 40 or 50 mammograms can be done. With the population which has been there, it's not something practical on that. So we are working with a couple of startups to look at the handheld devices and kind of stuff to work on. And iBreast is one of the devices which we are working with the U2 technologists. Recently, I had another conversation with a Bangalore startup called Sinha. They do on a thermolytics-based screening program. We just want to make sure that whatever the solutions we bring in are well validated and then which can scale up on that one. Not just for India, but I'm also looking for the other parts of the emerging markets where we can do it. And there's a large sections which has been where they can't come to a treating center to get an initial screening to be done. Okay, when there is a high risk population, you can always take them to a treating centers and do a definitive diagnosis. That's the diagnosis part of it is there. And as well as the innovative drugs are concerned, you are sure that one is we have been working with you for a while, which has been there. Is why always my personal philosophy has been that it has to reach the broader population. Okay, that's the innovation then which has been there. And Pfizer is committed in supporting on the below the poverty line patients. We continue on working that. I'm just giving one of the examples over there. There are various models which we are working for different countries over there. So I look at various aspects when I tell the equitable care to come in a drug development process, in the diagnosis part of it, getting across in the drugs in the patient's hands. So that's whole spectrum I meant when I'm telling on the equitable care. Now, moving on to the vaccines, yes, we are absolutely proud. It's a speed of science which never thought of. 243 days exactly we took for completing the phase 2, phase 3 clinical trial to complete a 44,000 patients trial. Never thought, and this helped us to think beyond what was conventionally we were doing across in every aspect of the drug development process over there. And more meaningful is that when the world needed, we stepped it and bought this vaccine in record time. And it also encouraged for me is that even the other companies to start looking at it. It's not just Pfizer, because it's once one company is looking across, there is others also will start looking. And overall, we partnered with academia very well, industry partners. We are once again looking across even the scaling up of manufacturing with other pharmaceutical companies. So there is a lots of innovations which we looked at it, and people told that we can't ship logistically, this will be challenging. We got solutions even for that one, right? You can get this vaccine shipped across the globe, and then the patients can get that one. So there is an innovation at every step which we did it. For me, it's good that we were able to come. It's kind of a once in a lifetime opportunity when really the whole community is looking up to a pharmaceutical industry. We were able to be there, but we need far more to do it. We have done our first part of it, a regulation approvals which has come in. We need to scale up the manufacturing, make sure that once this vaccine reaches to as many population as possible. I'm glad that the other companies are also working, because it's just not one company can solve the solution. We can't manufacture at that pace which has been there. So I hope that this reaches to a larger community. And we can come out of that fear and anxiety and get to the near normal process. That's one of the things which is required. And as earlier mentioned, and screening has taken a huge beating around the world. And we are doing specific campaigns over here is that like I mentioned earlier, cancer cannot quarantine. We're asking the patients as well as the general public is to go out and get themselves screened, or if they're already been diagnosed, don't delay your treatments. You can go out and do it. And you are, of course, you need to take the right precautions when you're stepping out and looking for the treatments on that. Yeah.
Thank you, Mr. Kumar. And like you mentioned that, the National Cancer Grid, which is working from Tata Memorial Hospital, now has over 210 hospitals as part of the National Cancer Grid, and a few organizations like us who are part of it. And I think couple more. So Girish, I think what I need to ask you, the question that has come in is whether, what are the resource challenges that you have faced, because you have really looked after the patients, and are you now getting sufficient funding? That is a question which has come from the audience. But also I want to add on that, just like the National Cancer Grid, which is hospitals and doctors, can we not think of working on a national cancer grid for all the NGOs? So we work in collaboration and we can support each other and, be innovative about, like Mr. Kumar mentioned, innovative ideas, and each one of us can implement something which can reach out to the patients. Your comments, please.
Yes, Vandanaji. And I think it's a irony that today I'm the only person who's not traveling, I guess, amongst the panel. So to answer your second question first, you spoke about NGOs forming, being part of the National Cancer Grid, just like the hospitals are. And I think it's a wonderful idea. And I believe you're also one of the few persons who have always told us that, if there are NGOs who are doing similar work, and then, we should probably not try and, be in that same area. If somebody is doing a job there already, we don't need to. So the idea should be to find out which are the NGOs doing specific work. And if, there is already a organization which is doing similar work, probably the other organization can look at different areas, and that way the reach can be better. So yes, it's a very good idea to sort of, be part of something like that and, extend our services along with the hospitals through the National Cancer Grid. And to answer your question on funding, fortunately for us, Vandanaji, since we are not we are a relatively young organization, so most of our donors have been individual donors. And what we saw during the COVID was the individual donors actually, they kind of, stuck with us, they supported us, they realized that, this is a difficult time. In fact, we had one or two corporates who sort of, backed out when they saw that, their quarterly numbers are, sort of not in par with the year-on-year profits. So we had some sort of surprises there, but what really surprised us was the individual donors who kind of stood with us and supported us, helping us to provide all the services that we are giving to our beneficiaries.
Okay. So actually we have so many things to ask and so many things to discuss, but knowing that we are going into Mr. Kumar's Saturday weekend, Dr. Purushottam's appointments, and I'm sure you have lots lined up with the patients. So we will have to call it a day. So Jogita, all yours. Thank you.